I will switch to English now. It's a great pleasure to introduce to all of you the first keynote speaker of this conference, Dr. Sarah Vinson. After studying in Cambridge and Harvard, Sarah became a specialist in adult, child, and forensic psychiatry. And nowadays she takes care of patients with diverse variety of socioeconomic backgrounds. And she uses also her expertise to advise in law cases across the United States. A great warm welcome to Dr. Sarah Vinson.
Good morning. It's a pleasure to join you this morning and talk about social injustice and mental health. It's a topic I've thought a lot about, co-edited a book about, and want to acknowledge my co-editor, Dr. Ruth Shim, as we begin this talk. We don't have much time together, and with that in mind, and given the breadth of this topic, I want to level set from the beginning that this is not about what you think or about a recitation of facts that I want you to memorize. This is more about how you think, and my hope that I challenge your frame just a bit this morning. So I'll start with, how do you define mental health? And this may seem like a really elementary question to ask a group of psychiatrists, but I think it's useful because our medical system, our frame is one that is often focused on pathology and diagnosis and illness. We talk a whole lot less about health than we should. And the World Health Organization says health is a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to her or his community. And I welcome you to reflect on how there's nothing in that definition about medication adherence, or treatment compliance, or symptom rating scales, or diagnosis codes, the things that we spend so much of our time thinking about and documenting and writing about. That this definition calls attention to the fact that mental health happens in the context of relationship. It happens in the context of society. It happens in the context of opportunity, or perhaps the lack thereof. And so there are bedrocks of mental health that we know as mental health professionals, such as agency, safety, and autonomy. And society plays a role in how people experience these things, or how they go through life, perhaps having these things constantly at risk. And so often I'm giving this talk in America and to American audiences, but I think there's some parallels here, so bear with me for a second. But I'm born and raised in the US, but had parents who made a point to give me the real history and the full history of our country, a history that's not always reflected in the school system. And one of the things that is really relevant is that America has this brand, if you will, of being a place of liberty and justice for all. And so that can make it really difficult for people to sit with uncomfortable truths about inequity and injustice in my country. And it can make it difficult for people who have benefited from being in a position of privilege, or who maybe didn't start in a position of privilege, but who had the opportunity for an educational experience that changed their societal standing. And for the most part, people who become physicians or psychologists or social workers, people who are in a position to diagnose and treat people, are folks who come from that privileged background. And so there's a gap between our lived experience and the lived experience of those that we serve. And so it's important that when we think about America, when we think about the American dream, when we think about Western medicine, that we acknowledge the denial of colonial trauma, the denial of racism, and understand that embedded in our very diagnostic systems, the DSM, which comes from the American Psychiatric Association, are racism and classism and all kinds of other isms, one of which I'll highlight as we go through this talk. I am from the South in the US, which has a reputation for being more overtly inequitable and more overtly racist, but I trained in the Northeast at Harvard, and it was a really interesting experience because what I found is the North wasn't any less racist than the South was, But there was this idea about who people in the North are and how the North is different. And that idea that we are more intellectual and egalitarian in the North of the US made conversations about racism more difficult to have because it flew in the face of how people like to see themselves in that region of the country. But it didn't make it any less taxing on me or any less relevant to people's mental well-being. And my guess is that there are some parallels here, potentially, that in a society that prides itself on equality and more egalitarian values, that sometimes it may be even more difficult to have conversations about inequity and injustice here. And so something I always ask people to do in clinic, or as we're talking about these concepts, is to mind the gap. All of us go through life drawing from our own lived experiences as a default. There's nothing wrong with it. It's something that helps us navigate the world. But we can run up into trouble when we do that and we project onto people who have different lived experiences than we do. And so it's critical that we always mind the gap. And some of you, I'm sure, recognize this. And if you've been on the subway in London, you hear it come over the loudspeaker again and again. The repetition is there because missing the gap is a big deal, right? Missing the gap when you're treating people, when you're diagnosing people, when you're trying to help them navigate the world is a really big deal. And so there's a certain amount of repetition and a way that we have to keep this front and center as we're trying to do our work. So social justice. Of course, the title of the talk, assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. When we set out to write the book, Social Justice and Mental Health, that was the name, Social Justice and Mental Health. But what we found is that as we read more, as we wrote more, as we edited more, the story was really one about social injustice. So we actually went back to the publisher and changed the name. So as you think about this definition, think about how this is present or the degrees to which it may not be. And so some principles of social injustice. So essentialism, the belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. Erasure of context, when we fail to appreciate how societal circumstances drive inequities, and biological determinism. And so when we think about these principles of social injustice, I would ask you to consider how these could undermine that definition of mental health from the World Health Organization that was shared earlier, and also to consider how these types of oppression could do that as well. So exploitation, the unequal exchange of one group's labor and energies for another group's advantage and advancement. Cultural imperialism, establishing the ruling class culture as the norm and othering of groups that are not part of the dominant culture. Powerless, marginalization, and violence. And I'll sit with cultural imperialism for just a minute because it's one of those things that shows up in clinic quite a bit, or maybe in conferences or well-intentioned seminars about cultural competence. One of the things that you see happen is labels like over-identification that are applied to people of color who are clinicians, who are treating people of color, who are patients, aren't applied to white clinicians treating white patients. It's a label that's almost reserved exclusively for people of color. And that comes out of this idea that white is the standard and white is correct, and things that are different are othered or given some kind of label. Often when we talk about differences in health, we use the word disparities, which is just a way of saying that these are differences in health status among different segments of the population, and this can occur by gender, race, ethnicity, economics, or income. But most health disparities, if you look at them longer, if you sit with them and consider where they come from, aren't just disparities, they're inequities. So what's the difference? Disparities in health are a result of systemic, avoidable, and unjust social and economic policies. And I would challenge you that if you apply this to what you see in clinic, to what you hear talked about, to what you read about in the papers, that almost everything that is framed as a disparity is actually an inequity, if you would consider that. So disadvantage in diagnosis. So Judith Herman, in her book, Trauma and Recovery, says the developing child's positive sense of self depends on the caregiver's benign use of power. And in that book, she's talking about the ways that trauma that happens over an extended period of time, that happens in the context of a relationship, and that is inescapable, is a different kind of trauma than a trauma that is more circumscribed or a one-off. And she's talking about childhood trauma and family violence in her book, but I would posit that when you're discussing structural trauma or social injustice, there are parallels there, that these systems are powerful, that these systems are inescapable, that these systems are a part of your life for the entirety of your life. And so there's a complexity to that trauma that we may not capture, and that our diagnostic structure certainly does not. And so when you're talking about social injustice, of course, the isms come into mind: racism and ableism and classism and sexism. And one of the isms we don't talk about as much is adultism, and I'm going to use that by way of example this morning. And so with structural adultism, it's the normalization and legitimization of historical, cultural, institutional, and interpersonal dynamics that routinely advantage adults while producing cumulative and chronic adverse outcomes for young people. So whose trauma counts? When we're thinking about our diagnostic criteria or in our widely used instruments, what we see is that criteria A for PTSD, for example, is largely based on people who have gone off to war or people who have experienced sexual assault. It's not based on things like racial trauma or trauma that comes with a horrible immigration experience, or trauma that comes with being part of a group that has been systematically marginalized by a society. Those traumas don't count, even though on some level we all know that those are things that are going to affect how people think, feel, and behave, their mental health. And so there's a way that we are set up to overlook, to undercount these traumas, and to be bystanders in our own right professionally. So we're going to take the example of oppositional defiant disorder. So you all know this, especially if you're a child psychiatrist, but it's a diagnosis that's given to children, and it's based on some diagnostic criteria that I'll go through very quickly, in a pattern of angry, irritable mood, argumentative, defiant behavior that lasts for at least 6 months, and then the person has to have angry or irritable mood, argumentative or defiant behavior, or vindictiveness. But we know that parenting can elicit these behaviors in children. So things like poor monitoring, harsh and inconsistent discipline, differential treatment of siblings, or maybe parents who are overbearing. And so the child gets the label because they're manifesting these symptoms, but often it's presumed that the adults in their lives have been responsible and caring and trustworthy and consistent. So when they're angry, sometimes we don't ask the follow-up question, does the child have things to be angry about? Have the adults and systems in their lives been consistent and helpful? If they're angry or irritable, there are so many different explanations for it that could be at the root of it, including things like neurotoxic exposures or PTSD or depression. It's a highly nonspecific symptom, or even argumentative or defiant behavior. When you have people in your life who are in positions of power who haven't exercised good judgment, or who have harmed you, or who have lied to you, or who have disappointed you, it can be understandable that they may be quote-unquote defiant. And so the child, which is the member of the disadvantaged group, because the adults make the rules, the adults write the criteria, the adults interpret the criteria, the adults give the label, while the behavior of the advantaged group, the adult, is presumed to be right. So the child gets the label, the child is pathologized, when their response and context may actually make a whole lot of sense. And so an individual reaction to a systemic problem is pathologized. And we see another version of this in the broader society. So just as a child's behavior takes place in the context of a family system, so too does a family system's functioning take place in the context of a larger society. This is still of a video of a young black boy who was playing basketball in his front yard. He wasn't doing anything wrong, but when a police officer drove by, he hid behind the car. Now, if you don't understand the context of this, you could say, is this child paranoid? What's wrong with him? If you understood that he's a black boy in the US the summer after the country watched George Floyd be murdered by police, you understand his behavior differently. He doesn't look paranoid anymore. He looks like a scared child who identifies with someone who he saw murdered by people who were actors of the state. So this brings me to advocacy. And so I looked up your mission statement as an organization, and it's about the promotion of psychiatry and the promotion of psychiatric practice. And I would like to challenge you all this morning a bit, and to think about what it would look like if you, as a group of people with the privilege and the platform you have as psychiatrists, to think not just about the practice of psychiatry, but to commit to a promotion of the population's mental health, which is a much broader mission and one that I think you are well equipped to take on. This guy, some of you may recognize, his name is Willie Horton. He's a famous bank robber in the United States and was interviewed by a journalist, and they asked him, Mr. Horton, why do you rob banks? And his response was, because that's where the money is. And I bring Willie Horton up to you today because if we're thinking about societal mental well-being, the money is in our society, in our populations, in our community. And that is where I hope that we as a field can be. So I learned about Dr. Glenn Helberg last night, who is one of your own, I understand. And it was really interesting reading his interviews because there are so many talking points that he had that are absolutely identical to mine. And he talks about how he has traded, and he said, I have traded my consulting room for society to stand up against the problems whose personal consequences I encounter time and again in my practice. People are marginalized by the current system and literally become ill as a result. I could not agree more. And I'm not saying that all of you should give up your consultation rooms like Dr. Helberg did, but there are ways that you can be part of advocating for a society that doesn't generate so much psychopathology. And so there's 4 steps to advocacy. I'm really glad that you're listening to this talk this morning, but this is not the work. The work is continuing to develop a knowledge base, recognizing injustice and your role in it, responding to injustice, and then iterating and sustaining. So the response that you have, measuring to see if it has the result that you want, and understanding that this is a long-term process. And so the final question is, how can every person realize their own potential, work productively and fruitfully, and make a contribution to their community in a society that fails to assure equal access to liberties, rights, and opportunities, and chooses not to care for its most disadvantaged members? And I would say that a society cannot, and if you remember back to the beginning of that presentation, that's the definition of social justice and the definition of mental health. And I'll end with a quote by James Baldwin, who said, "Ignorance allied with power is the most ferocious enemy justice can have." My colleagues, you have tremendous power. I hope that you take it upon yourself to learn about these issues and to apply what you learn in the practice of our profession. Thank you.